Morning.
Very good morning.
Welcome one and all to Equilogues 2017. Good morning and welcome one and all to Equilogues 2017.
Good morning. Good morning, Malu.
Yes, thank you, ma'am. So, as all of you know, Equilogues is a series of webinars which is conducted by Achutamenan Center for Health Science Studies under the project Closing the Gap Health Equity Research Initiative. And we have been conducting webinars once every 2 months on topics related to health equity research. Last week on 15th June, we had a webinar by Professor Sanghmitra Acharya, Director, Indian Institute of Dalit Studies, and she's also a professor at Center for Social Medicine and Community Health. She had spoken about health and well-being, understanding persistent gaps across caste and gender. Unfortunately, due to technical issues, we could not broadcast the webinar completely. So, to make up for it and to make sure that we get a complete idea of the topic, a better picture of the topic, we have arranged a live question and answer session with the same speaker. So, we have Professor Sanghmitra with us online today to clarify our questions and to give more insights into those areas which need further clarification. So before we start taking the questions, I'd like to just remind all of you that this is an audio only webinar, and so all the questions that you need to ask, you have to type in those questions in the chat box by the side of the YouTube video that you're watching right now. And before we start the actual question and answer session, I'd like to hand over the microphone to Professor Sanghmitra so that she can give us a quick recap of her presentation. Over to you, ma'am.
Okay, thank you so much, Malu, for organizing this question answer session, which we couldn't do it last week. I think it's also important, therefore, for us to be able to carry forward what we left at last week. I think I was trying to make my point in terms of suggesting that at this moment we know that there are differentials that exist across a varied social axis when it comes to social groups in which we have disaggregated the population, particularly in case of India. And to my mind, it's more important at this moment to be able to look at the processes which have in some way or the other perpetuated these differentials, and what are therefore the mechanisms which can be put together in minimizing those gaps. And that's perhaps why I did think of pitching in the issue of gender and caste intersectionality, because very often in the debate what has happened, we keep arguing that if you take care of economic inequalities, a lot of issues will be taken care of, but it really doesn't happen that way. There are issues of social identities which become very important, and they need to be addressed therefore. So by that logic, I had tried to argue that when we are pitching in for women, there are differentials across, not only from the point of view of figuring out what are the differentials vis-a-vis men and women, but also within the brackets of women per se, there are differentials. And by those arguments, I was trying also to suggest that therefore, women from vulnerable groups, Dalits being one, caste-based vulnerability being one, makes Dalit women most vulnerable in this hierarchy of differentials that we might want to see across any development indicator. So that those are the arguments I was trying to make using some of the live data from various data sources that we've had. I think I'll stop here and wait for maybe questions that will probably stream our discussion.
Thank you very much, ma'am. Thank you so much for that brief and crisp recap. So, the first question of today is asked by Professor Sundari Ravindran. Uh, the first question is that she first of all congratulates you. She says that it is a very well illustrated presentation about the pathways through which intersecting social identities of caste and gender affect health, and thank you for that. The question is, do you think discrimination based on these social identities can affect health directly, meaning not just through mediators like quality or access to health service? In other words, does the experience of feeling of being discriminated
Yes.
alone, do you
Yeah.
think it can impact health?
Yeah. Thank you so much, Professor Ravindran, for posing this question, because I think that this also allows me to share some of the ideas which perhaps I couldn't share earlier. Uh, it's really interesting to understand the health across these different trajectories. For one reason, that health perhaps is one variable which we try to explain by the elements which don't exist, in the sense like when we are trying to explain health is kind of a situation wherein you would not have illnesses happening to you, you would not have evidences of experiences which make you feel unpleasant or unhappy or up to the mark kind of a thing. So when we talk of direct bearing of these experiences of discrimination, some of which I have shared already, and maybe a good time point to share once again. When it's very difficult perhaps to talk in terms of discrimination directly, for one reason that none of the data sets that are available to us that at this moment allow us to do that vis-a-vis discrimination. They do allow us to talk about differentials, they do allow us to talk about variation perhaps, but to be able to label it as discrimination is slightly difficult, until and unless perhaps we may want to use some complex kind of allow us to explain the unexplained variables on the assumptions that, okay, since this is the quantum which is not being explained by other variables, therefore can be best attributed to the experiences of discrimination. Now, I'm making this point particularly to suggest that a lot of subtlety goes has hand in hand when the experience of discrimination happens at, let's say, a facility which would provide any kind of healthcare services. For instance, as a Dalit woman user, I might have to wait for slightly longer time in a PHC while I have taken my child to the doctor, for the reasons which could be visible as maybe it's too crowded. It could be visible because the person who's ahead of me is in conversation with the doctor, and therefore I have to wait for longer period of time, which sounds fairly all right to the eyes and to the conscience of the mind also. But there could be an element that well, she's the one who can wait for longer time, she is the one whose urgency is not really important, and therefore it doesn't matter if she has to wait for longer time. Now, this is something which is going to work on the user's mind in two ways. One is that the physical condition itself is going to be affected by the delay which is caused thus. Second is also the mental stress that the individual as a parent perhaps will be experiencing due to the delay caused, and the anxiety therefore that the rightful services which need to be provided at that time point are not being provided. So therefore, to my mind, it's not only the indirect outcomes which will yield a result on the health of this individual or the child, but also on the attending person vis-a-vis her own health, both mental and physical, in terms of the very direct impact that that situation could be causing. So it has to be seen in the complexity of what are the social environments in which such a nature of healthcare seeking on one hand and healthcare service provisioning on the other hand is happening. That's what I would want to point out at this moment.
Thank you, ma'am.
Malu.
Prof-
Thank you, ma'am. Go ahead, Malu.
I don't know. I'm hearing an echo.
Hi. Hello, Malu, can you hear me?
Yes, ma'am.
Okay.
Hello.
Hello, I'm here, Malu.
Yes, ma'am. Professor Sundari has another question.
Yeah.
She asks that you have spoken about the need for developing means to end these vulnerabilities. So,
Yes.
however, in your presentation, you could not dwell on this more. So, could you dwell on it a bit now?
Yeah. You know, I think it's really important at this time point, like I said at the beginning, also, we're very well aware that the differentials exist, and what's the need of the day at this moment is that what are the means that we can put in place. Now, to my mind, it has to be addressed in a multifaceted way. Policies are in place, for example, but the implementation of the policies which ensure access to services become more important. And when I say implementation of the policy, it simply doesn't mean that there are personnel put in place for implementation. Along with the personnel, I think what is equally important, and to my mind very important, very, very crucial, is the mindset of the people who are implementing these policies. And I want to argue it on this point for the simple reason, like if I go back to the example that I was using, if the sensitivity of the doctor is that the care is to be provided to all that come to him or her. Now, hypothetically, yes, that is what happens. But we are all human beings. We do get swayed away by our own socialization processes, and by that, I think we also prioritize whom do we attend as a provider first and whom perhaps we do not even attend. As a grassroots level worker, I have a lot of discretion in terms of which are the areas I would visit first and the second, and then maybe perhaps not visit also, because the voices in the community who are stronger, who would probably question me and not my provisioning of the services, perhaps I would ensure I would make my visits to those areas and to those people far more frequently and regularly as mandated as compared to other groups. So the voices, therefore the sensitivity of the providers towards the work that needs to be done, the way it is mandated is extremely important, because there are evidences that despite the visits mandated for different sector of people, different sector of the areas within the localities which are prescribed for visits, are often negated. And I absolutely take cognizance of the workload of the providers also. And therefore, perhaps it's also important to ensure the very, to make sure that the positions which lie vacant for long duration of time are taken care of. And, there are certain mechanisms to make sure that no position can perhaps lie vacant for a given amount of time. So the vicious cycle of being able to provide these services in terms of personnel, in terms of infrastructure, has to be also taken into account when I'm talking about the mechanisms. So policies have been in place for a fairly long time. Implementations have also happened, but what is it that we still lag behind? Perhaps the only therefore the unexplained variable remains is that the mindsets with which these implementations happen. And therefore therefore addressing the ways these mindsets can be address there can be certain ways in which if need be, not only the sensitization workshops, perhaps to some extent, but also perhaps some kind of maybe penalty if a certain amount of care is not being dispensed to a certain set of people. So that's one thing which I very strongly feel is important at that time point to address is the mindset of the providers and also the co-users of the care provision. Because why should I be given priority as a user just because I happen to be, not from the underprivileged backgrounds as compared to somebody who happens to be from an underprivileged background? The idea very often is put forth that there is no awareness among the underprivileged groups, therefore they cannot go and access care. But what's important for the provider is to be able to figure out what is the reason why the awareness remains so low. Is it only because me as a user from the underprivileged group is not interested in being aware, or is it because there are no ways in which I can get the awareness happen to me? Because somebody who may be the person responsible for creating that awareness in the underprivileged groups is not really in a position to be able to disseminate that kind of work which has been ascribed to it by way of workload, by way of distance, and there could be plenty of other reasons. And that's why I think the complexity of personnel and the infrastructure and the mindset becomes extremely important to be able to address this question, which seemingly becomes complex and more complex. Malu.
Yeah. Thank you, ma'am. So the third question of the day is posed by Dr. Srijani, who asks, within the backdrop of the nature of discrimination, could you explain the difference in understanding overt discrimination or over covert discrimination? I'd like to club this question with another one, similar one by Bevin, who's also a PhD scholar from AMC. He asks
Okay.
whether discrimination you have in your presentation you had mentioned about discrimination faced by Dalit children and also
Mhm.
women. So whether you have looked at it from the
Yeah.
point of view of the provider on why they discriminate, and when the intention is not exactly to discriminate, but whether when it
Mhm.
is perceived by the receiver as or the user as discrimination. So how do you see that?
Okay. Okay, maybe I'll start with the last question. The intent to discriminate is something which is it's perhaps not so easy to be able to discern. But if we go back to some of the theoretical understandings of discrimination, and I'll fall back on the work of William Darity, and the literature which evolves roughly around 50s and 60s, which talks about the taste of discrimination. Just that based on my socialization processes, I have developed an understanding which allows me to perpetuate certain kind of discriminatory practices. For instance, coming back to our own backdrops, when we look at our own scenarios of urban domestic help, for instance, very clearly, and there's literature which supports it, that when you're looking at who is providing the domestic care, domestic help in different spheres, who's the one who goes into the kitchen and does the cooking versus who's the one who goes into the toilets to do the cleaning versus who's cleaning the dishes and the clothes, etc., etc. And there's a very neat divide between the social attributes of the individuals who are assigned these jobs. Very distinctly, somebody who's assigned the job of cleaning the toilets is very, very rarely allowed to do the cooking. Now, by that argument, what I'm trying to say is, it could be simply visible that it's because when I'm doing the cleaning jobs, I am unclean, I'm dirty, I'm still to go and take bath. Then, therefore, it's not a very wise thing to do something which is clean, which is cooking, which needs your hands to be washed and so on. Overtly, yes, it's visible at that level, but then can there be an underlying reasoning which is coming based on my socialization, that these are the people who've been ascribed certain jobs, and therefore why I'm going to do let them do only that amount of it. So to be able to distinctly label what is discrimination therefore becomes important for us to move beyond the quantitative data per se. It is certainly very important to be able to get to the narrative experiential data, which will then suggest, will allow us to disaggregate or rather support what the quantitative data based on the differential will be able to tell us. So that's my take when I would want to distinguish between how the covert versus overt quote unquote discrimination can be visible. And coming back to this example that I had perhaps cited for the children, in the Anganwadi setups, it's more than one study now which has been trying to bring to the public domain that children are very, very categorically seated separately. On the pretext that the parents have have shown certain resentment that the children should be seated together or served alongside the other children when they are in the centers like Anganwadi Center. And these are public services that we are talking about. So public services don't exist in vacuum. They have to be functional within the social backdrops of whatever wherever the context is. And therefore I think it becomes extremely important to take note of what could be the underlying reasons for doing what an individual could be doing. And therefore I think it's important to understand what I would want to connect with the argument of taste for discrimination. The other question perhaps which I can connect with this only is, it's very not really evident, if I can use that word, when we are sitting in let's say spaces such as any healthcare receiving centers. Like all of us as users perhaps can be as vulnerable to any kind of a situation, but to react to that vulnerability within the frameworks or within the backdrops and understandings of how do I see myself as a provider? How do I see myself vis-a-vis what is mandated for me as a provider? How much of the meticulous provisioning therefore is happening within the mandate? And I am in cognizance of my limitations also in terms of the provider. So to be able to disaggregate what are actually structural barriers versus what could be the barriers imposed because of the socialization can be a tricky argument. And therefore I think some of these decomposition methods that many of us are employing on the qualitative data is trying to help us reach closer to that kind of a dimension. So that's where perhaps I would want to place my argument at the moment.
Thank you, ma'am.
Clear enough?
Yes, ma'am. Thank you, ma'am.
Yeah,
So the next question is from by Rajalakshmi from Chennai. She
okay.
requests you to just briefly summarize the key problems faced by Dalit women among the urban poor with respect to accessing healthcare. And I would
Okay.
like to couple it with the question by Dr. Tanya Sheshadri, who asks, how could the health department reform its services based on these issues? She also requests if you could share an example to highlight such a reform.
Okay. Thanks, Tanya and Rajalakshmi, for your questions. I think uh, to me, what's important perhaps when we look at the issues of urban vulnerable Dalit women, particularly, if I can pose this question in terms of when we're talking about the urban spaces, slums become the most vulnerable spaces when we are looking at the general context of the urbanization processes by way of housing, by way of civic amenities, by way of infrastructure. So I would want to pose the vulnerability of women and particularly girl children in that context, especially when we look at accessing healthcare services. The couple of things which become very important to locate these urban vulnerable women, particularly Dalits. And I'm focusing on slums for the reason, like I said, if you're disaggregating our urban populations, a lot of our vulnerable population, be it the access of wealth or income or social identities, is in urban areas, right? And in urban areas, one of the important contexts which is emerging is that very often the housing units have very porous kind of let's say divides. The porosity of the housing units in slums directly make women, particularly girl children, all the more particularly vulnerable to all kinds of from harassment to ill health conditions due to the lack of civic amenities, which can be the overflowing drainage, etc., etc. And I'm talking of an average slum in, let's say, a metropolitan city like Delhi. And also because, of course, slums do differ in the nature by way of their age, by way of their location, by way of the kind of civic amenities which have been made available to the slums. But on an average, slums do have poorer civic amenities, which could be drainage, which could be electricity, which could be healthcare facilities also. It's when it comes to the healthcare facilities in terms of the provisioning, a good share of healthcare is being provided to the slum dwellers by way of the CSOs and the NGOs. There are urban health posts in some of these slums which have been recognized at the first level, and second, perhaps when vis-a-vis the efforts of certain other agencies, there could be provisioning of care both by public providers as well as private sector providers. Now, to be able to access any kind of service in public sector, we all know certain kind of documentation, availability of identity documents are very important. And the moment we talk of the vulnerable groups, that becomes an important issue. How a good share of documents either don't exist for this set of people, particularly women, and therefore it also brings them out of that regime of availability of any kind of support vis-a-vis healthcare from the public sector domain. So much of it then happens vis-a-vis other sectors, even the exposure that I can share vis-a-vis some work that I am involved in. Even the CSOs who are in in consonance with some public sector functionaries, providing health services to some selected slums in the city of Delhi. They also feel that availability of the documents, which can any kind of identity documents, become one major hindrance in terms of provisioning of the care services. So many a times there are alternatives which are sort of tried to be made in terms of ensuring that some kind of care can be provided. So that's from the point of view of how provisioning can get restricted by way of just about the need for any kind of documentary support of one's identity. That's one. The other is, if the migrant is if this is a new set of migrants into the city, issues when it comes to not only locating themselves within the slum, but also in terms of, again, not being able to have those documents. Now, by way of locating themselves, most often, like in any other process of peopling of a physical space, much of the newer settlers are in the fringes of the slums, and fringes again get by way of any kind of amenity which may be available in the slums remains least equipped with that kind of any kind of facility in that sense. The possibilities of it have lying at the physically lower level of the rest of the slums, and therefore the drainage becomes an issue, because that's the space which wasn't being occupied till now because of that problem. But now that newer streams of people have come, that's the only space available, and therefore they settle down, exposing themselves with this kind of health hazards. That's more in terms of the living environment that could be posing a problem. The other could be, as new migrants, there are likelihoods of the informal sector employment, which could have been made available to either either the male member of the family or the women. Perhaps normally it's the men who would be working, and women have seemed to be following suit a little while later, mostly in the sector of domestic help. In that case, when both parents are away working, the next issue becomes important in terms of providing safe spaces for the children who are left behind. And safe urban spaces also get contextualized in terms of the immediate physical environment in which those children are being left alone. Are those the sanitation facilities fairly good for these children to be left behind, without flies, without overflowing drains, with adequate supply of water, with toilet facility, etc., etc. And given an average slum, I'm sure a lot of it does not really happen that way. So the exposure doubles when it comes to the women user of any kind of health facility, and of course the children, particularly girl child, if I can look at vis-a-vis her vulnerability to perhaps assaults of different kinds. Not that the boys aren't, but the point I'm trying to make at this moment is more in terms of um, the conventional thought, which makes man the breadwinner kind of a scenario, usually is likely to have the identity documents, before the woman can be thought about getting the documents. So at this point, I think ensuring that some kind of you know how does one get these documents with, and I'm sure there are a lot of other issues which connect with enabling an individual to get these documents for various reasons. They also become a hindrance. Non-availability of these documents also becomes a hindrance in accessing, therefore, any kind of care. And we would agree that when I have to, as a user, daily wage earner, or a domestic help, go and access private sector care, it's an entirely different kind of issue for me, because using the whole day of my wage waiting, etc., etc., could be another kind of a problem, which again hinders me from using that kind of a facility. So there are issues which start not only from the identity documents, but also in terms of the nature of provisioning which could be happening, and which therefore needs to be changed to ensure that services can be made available in the ways which will actually be accessed. Malu.
Thank you, ma'am. Thank you. So before moving on to the next question, I'd just like to tell our listeners that we would be able to pose only one question per person considering the shortage of time. So for the other questions, they would be mailed to Professor Sanghmitra, and the responses would be sent to all our listeners. So please bear with us. This is because of shortage of time. So the next questions actually are by Dr. Ritu and Sunu, who are faculty. Both the questions are speaking about focus on a certain group. Ritu asks that media gives more importance to violence and negative health outcomes among Dalit groups, and she speaks. Is it right in targeting or focusing those groups specifically? And Sunu asks another question, that this intersection between caste and gender placing undue burden on women is not just restricted among one particular caste, say Dalits. This undue burden on women because of casteism occurs in other groups too, other even religious groups. So is it right, or is it right to restrict our discussion to just one group of women like that? So these are the two questions.
Okay, you might have to repeat the other question after I'm done with this one. I think I didn't get the first question very well. If you could repeat it right away, maybe I'll take the two together.
Yes, Dr. Ritu feels that there is an undue focus on
Oh,
one group, say
mhm.
Dalits. So
Okay, okay.
he speaks. I mean, her question is it right to just, are we doing justice to that group by just focusing on
Uh,
them? That's what she
Okay,
asks. Okay.
okay. Yeah, I think it helps me put the two together. Uh, I would not say that it's an undue focus on one particular group. Uh, the focus perhaps needs to be directed to some particular groups. And in this case, I chose to talk about Dalits for the simple reason that when we talk about the differentials with which I started my presentation. There are issues with different social groups. And I did discuss that how other groups who can be marginalized by way of gender as an identity, for example, or ethnicity as an example, that can be reason for my vulnerability. Religion can be another. Caste I was posing as one, and I was trying to say, and I'm sure we'll agree that one axis of marginalization, which other margins, other axes don't really that uniqueness which caste has in terms of the hierarchy which is embedded in that, the notion of purity, pollution which is embedded in that, the notion therefore of being untouchable, being unseeable, etc., which is endowed with caste, doesn't seem to be impacting on other axes. And that's why the focus on caste is of a different kind, and it needs a different kind of address, therefore, as compared to other axes. And that's the reason why I chose to intersect caste, therefore, with the vulnerability that could be gender. That's the reason why I thought I would come up with arguing for Dalit women particularly, because I'm sure the idea of other women also being marginalized in some context or the other is absolutely agreeable. There's no question about it. But when we talk about women per se, in terms of, even if you look at the movements, many a times the argument has remained that most women or all women face similar kind of problems. So the vulnerability of women on one count or at one level perhaps cuts across these differentials. But that is where I would want to argue that these differentials need to be therefore addressed. All women need not face similar kind of vulnerabilities. The hierarchy in vulnerability across women is also important to be taken on, and that's the reason why. And I might want to take on the example of sexual harassment, for instance. When Dalit woman is sexually assaulted, the mindset of that assault is different than when a tribal woman is assaulted, when a non-tribal, non-Dalit woman is assaulted. And I say this with very complete consciousness that the hierarchical system of the society in which we exist allows us to believe that women of Dalit communities are uh, at the lower rung of the society, are to be treated in a particular way. And therefore, it's all right if any kind of such assault is being done to them. And there, the newspapers, umpteen, a day's newspaper will have n number of write-ups or reportings on this kind of issues. So the argument I'm making is that the difference based on the process of socialization, the hierarchical structure in which we exist, and therefore the consequent mindset makes the issue of Dalit women very different, and therefore the need to focus on Dalit women separately as compared to women outside other groups. And therefore the context of the needs of the health also concerns for the health also, because the support system which could be available for other women will be very different from the support system that could be available for the Dalit women, and therefore the thrust and therefore the need for the focus of the kind that I'm trying to give.
Thank you, ma'am. Um, Ma'am, the next question is by Tomba Asim Mithi, and he asks, how do we contextualize the lived experiences of discrimination faced by Northeastern people in India within the domain of casteism or racism or both?
Okay. Thank you, Tomba, for this question. I hope you're doing fine. Thank you for bringing in the context of Northeastern women, and I'm really happy that you brought it, because many a times when we talk of Northeast India, we forget that caste could also be existing there, and many a times we try to sort of overlook the issues that could be there. Uh, I said just a while ago that when it comes to the marginalization or discrimination which is experienced by women from marginalized groups, and ethnic groups being one of them, these it becomes slightly of a different kind, because one when we're talking about the exclusion of the marginalized groups, it's to a large extent based on the physical exclusion. It's largely based on the exclusions of the kind which are based on appearance, for example, based on food habits, for example, based on the way clothings happen. So that the whole context of any kind of interaction which can which is a lot in kind of supported by the stereotypical understanding or perceptions of specific groups becomes very relevant when we try to understand the marginalization or vulnerabilities of the women based on the ethnic identities. The second point, which I would probably want to make it, like I said, the regions, the states which are in the northeastern part of the country could be having they do have a smaller share of caste groups, but they do come from within the larger fold of the social dimension, the larger fold of the socialization process. But there are some evidences of assimilation processes which could be suggestive of the fact that the nature of perhaps differentiation, if I can use that word, which could be used by Dalits in that region, is likely to be different from that they could be experiencing in most of the mainland, if I can use that term, mainland, across the mainland amongst the women of different social fabric. So, and particularly the vulnerable, I mean, along the vulnerable groups, I'm trying to talk about that. So I think it's not that the vulnerabilities are similar, but vulnerabilities, different kinds of different structural context exist for women from the tribal northeastern ethnic groups and women who could be of Dalit backgrounds in those regions. If I've followed your question correctly, Tumba, that's how I would want to respond to it. Malu.
Thank you, ma'am. Although we still have a few more questions to go, and more questions are coming up, considering that we have already exceeded our time, I'm going to move on to conclude this session by picking two questions. One by Dr. Srinidhi and the other by Sabu Joseph. Both of them are PhD students at AMC. So Dr. Srinidhi asks about increasing discrimination within discriminated communities. That is, even
Okay.
that is, discrimination has become a ubiquitous practice in those communities too. And Sabu asks about how do we address the increasing inequality within the marginalized groups. So
Okay.
these would be our final questions for the day, ma'am.
Okay. Okay, thanks, Srinidhi and Sabu. Yes, you're right. There are increasing, evidences of increasing inequalities as well as increasing discrimination, perhaps, like you say, within the discriminated groups. I would want to go a bit further from there. One is when we're talking about the within the discriminated group, you know, why is it that we are seeing the increase? I mean, if you look at the National Crime Bureau reports, the evidences of reporting have increased. If you look at the newspaper, the reportings, you'll find the number of cases reported certainly have gone up. Now, one explanation which is most viable to my mind is that uh, when there are assertions of what was earlier being was considered acceptable and was not reacted to, it becomes that's the point when discrimination strengthens. And I'll want to cite it through an example. Mm, uh, when you hear the news item which says that young Dalit boy was made to climb down the horse on which it was riding to go for his wedding, or was brought out of the ambassador car on which he was going to get leading the wedding procession. Uh, the idea of being assertive about the fact that yes, even I can do the same thing like other non-Dalit boys by way of riding the horse or using the car for the wedding procession was a kind of non-acceptable kind of assertion by the other group, the non-Dalits, if I can use that term. Therefore, the reaction to that was the reaction to that kind of assertion is that how can that be happen, and therefore further strengths of discrimination. Now, within that group, there are, see, no group is homogeneous for that matter. There are certain axes on which we can identify the homogenities, and there are certain other on which heterogeneities can be identified. So amongst the discriminated group, there are some of them who are more discriminated versus those of them who have been more discriminated. Absolutely marginalized because there is no access whatsoever by way of any kind of state supported functionaries or state machineries, etc., etc. So those kind of gradations will always be there. Now, at two levels, one is where the discrimination necessarily needs to be perceived and seen in terms of and understood in terms of the Dalits versus non-Dalits, the discriminated versus the privileged groups, which is the example what I was citing at, the assertion coming in. And therefore, the reaction to the assertion of being able to do anything which is same as me, who is the better one, and therefore you're not expected to be doing that, and therefore the reaction to it in terms of discriminating further. Similar percolates down also at the levels which could be intra-group kind of discrimination. All of us want perhaps to have the better things as accumulated for one's own self. The moment there is a realization that somebody else is trying to take a share out of it, there is a likelihood of that kind of reaction to the I would say assertion. But this is something which perhaps also needs to be seen in the light of therefore the social inequalities which are inbuilt the moment we talk of any group in kind of any large group with the assumption of its homogeneities. Homogeneity, like I said, could be on a particular criteria. Within that, there will be heterogeneities if you're using certain other set of criteria. And that also therefore brings us to the whole argument of the evidences of inequalities. At the very large level scale, and I think I've shared that earlier also. It's when we talk about the wealth quintiles across the broad social groups, we see a larger share is tagged, almost a quarter of it is tagged at the lowest wealth quintile, both in terms of the scheduled caste population and scheduled tribe population, as compared to less than 10% when it comes to the non-Dalit, non-tribal kind of congregation. Talk in that sense. Therefore, the variation in the equality across social groups also makes a lot of difference in terms of how do we need to see this growing inequality. And this necessarily has to be seen in context of also what is the scenario vis-a-vis the unemployment that is also happening across the population group. Where is that share going in vis-a-vis public sector and private sector across different range of group A, group B, group C kind of employment that is available. And also we ought to be remembering that this is just about a scenario of public sector wherein we perhaps are referring in context of affirmative action. So a lot remains outside the affirmative action domain in order to make available or address any kinds of inequalities, if at all there is an intent to do so. Malu?
Thank you, ma'am. So with this, we have come to the conclusion of our live question and answer session. On behalf of Achyuta Menon Center for Health Science Studies, a Closing the Gap research project, and all our listeners, I'd like to extend my sincere gratitude to Professor Sanghmitra Acharya, ma'am, for that excellent presentation at the webinar, and also for your patience and cooperation with which you have clarified our doubts. I'd also like to thank all our listeners for their active engagement. I know that we have missed a couple of very, very interesting questions, but we promise that we will get back to all of you with the responses of these questions. And this video of the live question and answer session will also be available, uploaded into YouTube, and the link will be sent to all of you for your further reference. So thank you once again, ma'am, on behalf of all of us.
Thank you. Thank you, Malu.
Thank you, ma'am.
Thank you.